Can you hear me, Farnes?
I can hear you, but when I mute, I can't hear you.
Okay.
Clearly somebody is back with all of this. We'll be with you on all of this tomorrow. Thanks for joining us, gentlemen.
The process savers, the story with Marcus right now. All right, guys, thank you very much. Continuing breaking coverage this afternoon on Record Column and this story. And it's actually breaking at the same time in a few locations later here. Meanwhile, uptown, student broke the windows, jammed open the doors, then locked the doors. They're now occupying with lovely building to win for founding father Alexander.
Oh, there you go.
Yeah.
Okay.
We were unmuted.
Is that better?
Can you hear us now?
Yes.
Okay.
Yes.
All righty. Well, yes. I want to talk about the Latino epidemiological paradox and try saying that in Spanish. La paradoja epidemiológica latina. Okay. But really under its case in point of looking at, let's see, oops, the existence of racial narratives in science and medicine. Now, I'm a scientist. I'm a basic scientist, originally raised as an engineer. I wrote my first computer program in 1963 on an analog computer. Oh, you've heard of analogs. I learned on analogs. Then for fun, we got to do digitals. So I am a nerd. I'm a quant. However, I have also come to understand that there are racial narratives baked into a lot of the research that we do. In fact, I remember about 10 years ago, I was having lunch with somebody, and he knew I was from the School of Medicine, and I'm a basic scientist. So he said, oh, but science and medicine, they're objective, aren't they? And I said, well, there are methods, there are data, but science is practiced by human beings. And that's where You know, in engineering, we have an old saying, every time a human being touches a number, the chance for error enters. It's human beings that do it. So I just want to give an idea of how this can work as we look at what's been going on with artificial intelligence and facial recognition programs. What has emerged is actually they come out, these programs, with a code bias that goes like this. Now, in theory, artificial intelligence is neutral, okay? So you get your neuron unit, you expose that neuron unit to data, to input, and it learns, in theory, mimicking the way the human brain learns. Turns out humans have wetware. They don't have wetware, they just got hardware and software. Okay. Nonetheless, we try to mimic it. And this is science. This is computing power. You know, the new, well, it's about 3 years old. Neural engine, 600 billion operations per second, real-time processing. But where does this artificial intelligence get its knowledge? Well, from the network out there, from Facebook, Instagram, Twitter, LinkedIn, you name it. And what's interesting is that when it comes to the situation, you have a facial recognition phone, it unlocks the phone, you hold it up. With white males, there's less than 1% error. With white females, there's 7% error. With dark-skinned males, 12% error, and dark-skinned females up to 35% error. So the question is, how is it possible this so-called objective facial recognition based on AI could have a 1% error in white males and 35% error in dark females? Well, whose Facebook and Instagram and everything else are they using? Why, the dudes up in Silicon Valley. This is the world they know. They feed it in. And what is produced is called code bias. And they've been studying it a lot, particularly at MIT, where my brother-in-law just retired, and he was in logic, working in robotics. But biases in the real world can seep into artificial intelligence. And sometimes more than just seep, sometimes just comes galloping in. But people don't see it. Algorithms are not neutral, but are created by humans. I mean, I learned this 60 years ago when I was wiring circuits to solve things with by analogy. Well, I remember when this came out, this is just right before COVID. I was sitting at my desk, and so I thought, well, gee, let's see. Let me just Google doctor sitting at a desk. I Googled it, out came this. Now, if I were a young pre-med, I would look at that, and particularly if I were a minority young pre-med, I'd look at that and say, gee, all the doctors are white males. Now, was this just random error? You've taken your statistics, you would think, no, there should be a, random, should be a little bit of everybody. But look at the artificial intelligence and what it was exposed to. So then I thought, that's interesting. So I just typed in pediatrician, and suddenly it's all women. Okay, example here of code bias. So this is sort of my motto. Facts tell different stories depending on who is picking them and placing them in a narrative line. So with that, I'd like to look at code bias in the current narrative on diversity, race, and health. This came from the website of the Office of Minority Health. It's called the Minority Health Disparity Model. African American, American Indian, Alaska Native, Asian, and Pacific Islander, and Hispanic citizens. Now in California, that's about 3/4 of the population, okay, suffer poorer health and higher rates of premature death than the majority population. I'm sure you've heard this. I'm sure you heard this in classrooms. I'm sure you heard this in classrooms on this campus. So it's very deeply buried. In 2014, the recently released Centers for Disease Control and Prevention report, Health Disparities and Inequalities, demonstrates that African American, Hispanic, Asian American, and American Indian and Alaska Native populations suffer higher mortality rates than other populations. Okay, we get this all the time. And when the National Academies of Science, Engineering, and Medicine released its report on metrics that matter for population health, they came to the conclusion that the primary drivers of poor health outcomes are race and poverty. Okay, I'm an engineer. I've been hearing this all my life. But starting in the mid-1980s, once the data became available, I said, oh, I was taught this as an undergraduate at Berkeley in the 60s. Let's put some data to this. So let's put some data. So let's look at poverty, 2014, and it's continued up to this day. Latinos about twice as likely as non-Hispanic whites to live in poverty in California. About 3 times more likely not to have insurance. About 8 times more likely not to have graduated from high school. Okay. So these are called risk factors. I'm sure you've been taught them. Low income, low education, low access to care, and being of a non-white race then leads to disproportionate adverse health outcomes, higher mortality, shorter life expectancy, higher infant mortality, you name it. So here are the top 10 causes of death, the age-adjusted death rates for 2019, just right before COVID. And we'll get to COVID, but I want to take a look just right before COVID. Okay, the number 1 cause of death is heart disease, followed by cancer, unintentional injuries, chronic lower respiratory disease, and stroke. So let us look at the number 1 cause of death, which is heart. By the way, between heart and cancer, those accounted for 60% of all deaths they do in it. So these are like the biggies. We're going to compare, on the one hand, non-Hispanic white, and on the other, Latino, 2019. So which group has lower income? Latinos. Which group has less education? Latinos. Which group has less access to care? Latino. So which group should have a higher heart disease death rate? According to the model, should be Latino, right? So we look at the data, and that's not what we see. The non-Hispanic white rate is 165.8 deaths per 100,000. The Latino rate is 111.3, 30% lower. 30%. This is like multiple standard deviations. And we've done this around the country. And it doesn't matter what Latino group we're looking at. This happens to be LA Metro, where it's primarily Mexican and Central American. We go to New York, where it's primarily Puerto Rican and Dominican. We go to Miami, where it's primarily Cuban and Colombian. We see the same pattern. In fact, when we do this by state, and you have different Latino groups living in different states, this is alphabetically from Arizona to Texas, in every single state, the Latino age-adjusted death rate for the number 1 cause of disease is anywhere from 20 to 40% lower. Every single state. And I've been seeing this since 1985. So that's about 40 years. This is very, very stable, very robust data. Okay, well, maybe there's something unique with heart disease. Let's look at cancer, number 2 cause of death. Okay, which group has higher risk factors? Low income, education, access to care, Latino. So which group should have a higher age-adjusted death rate for cancer? You look pensive. It should be Latino, right? Should be. And we see the same pattern. The Latino rate is 30% lower. Now, again, I always bring my engineering days with me. In science, a model has to have predictive power. You want to predict what's going to happen. So in engineering, you can build a building that's not going to fall down with the first rainstorm. It's not going to sink. You have to be able to predict what's going to happen. So right here for the first 2 causes of death, and we see also broken down by state with different Latino populations living, the same general pattern. Anywhere from 30 to 40% lower. Okay, so you could go to number 4 cause of death, chronic lower respiratory disease. You know the drill by now, which group has worse risk factors. So which group we are predicting would have a higher death rate due to chronic lower respiratory disease should be Latino. And we look at the data, and Latino is 60% lower. And these are age adjusted. So here we have the top 5 causes of death for the US in 2019. The Latino rate in blue is significantly lower than the non-Hispanic white rate in yellow for heart, cancer, unintentional injuries, chronic lower respiratory, and stroke. So let's look at everything. That's just the top 5. That's only the top about 75% of death. Just throw everything in it, all causes of death. Which group has the worst risk factors? Latino. So which group will have the higher overall death rate? We can start at, wait, we already looked at heart, cancer, chronic lower, that's about 60%, 70%. So already we know the trend, and actually overall, Latinos have about a 30% lower age-adjusted death rate for all causes. And again, we look state by state by state, we see pretty much the same general pattern, some minor regional variations. Now, there is one exception to this: diabetes. Now, we've all heard about Latinos and diabetes, right? I mean, until it's coming out our ears: Latinos, diabetes, Latinos, obesity, Latinos, diabetes. It's the number 7 cause of death. How come we have never heard, oh, and 30% fewer heart attacks, 30% fewer cancers? We've never heard that. Diabetes, obesity, diabetes, obesity. Okay, well, as we start to look at this, it becomes clear to me that this is driven by chronic diseases that are called lifestyle diseases. Heart disease, for example, has a lot to do with what you eat, with what you drink, what you smoke, what you ingest, with whom, how you find spiritual solace, who are your family, etc. It's a style of life. It's not communicable. It's the style of life. And there seems to be something in Latino lifestyles, doesn't matter whether you're Mexican, Colombian, Salvadoran, Cuban, or whatever, that is reducing your risk to death. Okay, so let's go to the other end. We've been looking at death. Let's look at births. Here is 35 years worth of data on infant mortality. 25 years, I'm sorry, 1985 to 2010. This is non-Hispanic white. Now let's compare infant mortality. Comparing Latina moms, you know the drill: less income, less education, less access to care. Across the country, California is almost an exception, but across the country, Latinas, far fewer prenatal visits. They're initiated far later into the pregnancy. So which group should have the higher infant mortality? Okay, test time. How many think that Latinas finally will have higher infant mortality than white? How many think whites will have higher than Latina? How many don't know what to think? Okay, this is the beginning of wisdom. We have been taught these as eternal truths. And I'm looking at the data and I'm just not seeing it. So here is non-Hispanic white, and you lay in Latino infant mortality, and it's virtually identical, even though the moms live world apart in terms of income, education, access to care. Again, there's something in this Latino lifestyle that is producing spectacular birth outcomes over and over and over and over again. Okay, life expectancy. Remember what they said, the first few charts? Higher rates of mortality, higher rates of premature death, shorter life expectancy. So let's just go through it. Turns out, nationally, Latinos have a 3-year longer life expectancy compared to non-Hispanic white. This gets really personal with me. This October, non-Hispanic white is 78.6, Latino is 81.8. This October, I turned 78. And if I weren't Latino, I'd be making out my will and I'd be living it up. I got 6 months left to live. But I'm Latino, right? You have heard Viva la Raza. Oh, there it is. 3 years longer. And again, we go around the country, state by state by state. We see virtually the same pattern, with one exception. In New Mexico, oh my God, Latinos only live as long as whites. What's wrong with them? Why is it not 3? So clearly you get some regional variation, and New Mexico does tend to be a bit of an outlier on a lot of these. Not wholly. Okay. Lower death rates, lower infant mortality, longer life expectancy. How does that happen? Well, let's look at some other behaviors. Smoking. Turns out Latinos actually have a relatively low smoking rate, far lower than white. Heavy drinking, stereotypes to the contrary. I mean, who's out there getting drunk on Cinco de Mayo? It's usually not Mexicans. Okay. And of course, drug overdose rates have really been climbing, the deaths of despair, but Latinos still have very, very low rate. So this is why we look at Latino lifestyle. And you notice I've stepped around completely genetics because Latinos were so heterogeneous. I mean, when they do, for example, genetic studies on diabetes, they go to Iceland, where there's been no immigration for 1,000 years, and they have pretty good records. Very homogeneous. Latinos are just the opposite. We're kind of all of the above. That's why we have issues when the census asks our race. Okay. So that was before COVID. But how did COVID affect Latinos? Well, COVID was different from chronic. COVID was communicable. So you could be living the best lifestyle on earth, but I could walk up to you, breathe on you, and I could give you the coronavirus. Doesn't matter about your lifestyle because it is communicable. And Latinos were walloped by COVID. More illnesses, more hospitalizations, more ICUs, more onto, were intubated on a respirator. And my center published 14 reports on COVID in Latinos during the 2 years of the lockdown. So here's just the age group 65 to 79. And as you notice, the higher groups were Latino and Native Hawaiian Pacific Islander, just really, really high, far higher than non-Hispanic white. So why would Latinos have a higher death rate? If they're great on lifestyle, what happens with communicable? Well, come back to this. Facts tell different stories depending upon who is picking them and placing them in a narrative line. So I remember the early days, in fact, before COVID had got here, I worked with a lot of physicians in Spain. And so they were calling me because basically what they were experiencing, we were going to experience about 8 weeks later. It was coming around the world that way. So one of the things, some of the early research, both in China and in Europe, I pointed out that once you develop the disease, you were hospitalized, you're in intensive care, you're on a respirator. At that point, having comorbidities would lead to higher death rates than those who didn't have the comorbidities. Oh, well, that's immediately people jumped onto this bandwagon. Oh, well, Latinos have comorbidities. They're obese. Oh, you always hear about fat Latinos. Higher obesity. They have diabetes. That's what you hear about Latinos and health over and over and over again. My God, they're going to have a higher death rate. And in fact, when we started seeing the higher death rates, I started hearing, well, what do you expect? Obese, got diabetes? Well, of course, gee, nothing we can do about it. So we swung into gear because we look at the same data sets. While the medical world was basically looking at Latino dysfunction, we look at other things, such as, well, who was working? Now, you remember the first few months of the shutdown here at Ralph's, people were fighting at Ralph's over paper towels and toilet paper. But they didn't have to fight over food because Latinos in Oxnard, Latinos in Arvin, Latinos in San Luis Obispo went out to work every day. And we never had a food shortage. Maybe didn't have all the selection you're used to. We did not have a food shortage, not in California, not across the country. But look how they're working. No masks. They're in the occupation industries that often don't give them time off for illness, don't give them health insurance, wouldn't give them personal protective equipment. And they would go out to work in the fields, in the packing houses, in the freezing units, in the transportation, stocking shelves, being the checkout clerk, all aspects of the food industry without any backup. And of course, they're exposed to core workers, they're exposed to clients, and not just farm working, as in construction, automobile industry, transportation, caretaking, you name it, gardening. So Latinos were ravaged, not because they were fat and had diabetes, because they stayed at work. So let me give you some data on this. Labor force participation rate, month by month during COVID. Let's see. So here we start August 2019. The blue column is Latino labor force participation rate for that month. The white line is everybody else. So you notice prior to COVID, actually Latinos had a nearly 6 percentage point premium in labor force participation. Then, of course, came March and then April, and Latino labor force fell off. So did everyone else. Now, you may have heard that Latino labor force participation fell more than anyone else. Absolutely true, but it started 6 percentage points higher. And they always forgot to put that point in, you notice. And then, of course, we were wondering in April, will there be any recovery? Will it be a long, slow recovery? Will it be a V-shaped recovery? And there was a V-shaped recovery in Latino labor force participation. April, May, June, already back up to 65%. And month by month to August of 2022, back up to over 66%, while for everybody else, it's pretty much been stagnant. Add to that, Latinos to work in the occupations industries that you can't do by isolating at home. You can't grow strawberries in your front yard. It's that simple. And how do you get to work? Oh, you carpool, you take public transportation, and you're not getting PPE. And you didn't have health insurance. Do you remember the first couple of months when the Lakers were getting tested? And back in those days, you actually had to have your doctor's permission to get tested. You remember those, okay? And here are Latinos, first of all, more likely not to have insurance. There are Latino physician shortages. There are Spanish-speaking physician shortages. I mean, just the odds are stacked against people who are out there actively interacting with other human beings. So moving on from COVID-19, we're starting to see the end of the pandemic. So this is national level data. We haven't gotten yet all the, so the column in orange, that's the all causes of death, deaths. These are absolute numbers. Then these light pink ones are the COVID related deaths. So you notice none of those in 2019, a significant number in 2020, 2021, but by 2022, they were starting to shrink. By 2023, have really dropped. Yes, Latino life expectancy was affected. And I kept hearing, oh, this epidemiological paradox is over now. It's all gone because of COVID. COVID is communicable. And we're returning back to the epidemiological paradox. So here we have from 2017 to 2023 as a line function, all causes, age adjusted. This is for non-Hispanic white. So here we have the run up during COVID, and that'll just drop off. Here's Latino. Again, you're about 30% lower. A steeper run up because of the working conditions and social conditions, but also dropping off, not quite as rapidly, but coming back basically to where things were going back status quo antes. And I have had so many people say, well, the Latino epidemiological paradox, that's over. It's history. We'll never see that again. No, it's communicable. You have to distinguish between the two. They're very, very different. And the life expectancy is beginning to return. So here we have 2019, that 3 years life differential, life expectancy. 2020, Latino dropped, and you may have heard this, and it dropped more than anybody else from 81.9 to 77.9, but it started 3 years higher. So yes, it dropped more. Still at that point, a half year longer than white. White has continued to fall during 2021. Latinos pretty much stabilized. Now it's about a year, almost a year and a half longer. So we're getting back status quo antes. And yet, hear this, Minorities experience poor health and premature death because of pathological behavior that includes the choice to smoke, drink heavily, consume the wrong foods, engage in unprotected sex and violent behavior, and lead sedentary lifestyle. Boy, it's going to be a real job to get their health to improve if that were true. But it's not true. But guess what? People walking into the lab, what does NIH fund, by the way? Don't worry, I fight with NIH on this. I'm on the review panels. I review manuscripts for journals. I know what the chatter is out there. People believe this. I say, hello, Latinos, 40% of California, 63 million in the United States. And you tell me that in a matter of 2 years, it's all gone because of COVID? I don't think so. So we're looking at a lifestyle that we need to understand, particularly as we are supposed to be, I guess we are, reforming healthcare, and we are. Most of you seem kind of young. 20 years ago, we didn't have UCLA Health. We had a medical school and we had a hospital, and they just function in different universes other than, they sometimes shuttle patients over. At the UC office of the president, there was a vice president for health who basically kind of twiddled their thumbs because we have a medical school, we have a hospital. So did Irvine, so did UCSF. But just right before COVID, suddenly we became a system here at UC. We're now UCLA Health. And now we have bought our 5th hospital over in the West Hills. We've been setting up clinics, all within about 2 miles of the beach. We're now a system. And now the next step is it's going to be not UCLA Health and UC Irvine Health. It's going to be UC Health. And our goal is to become the state's 2nd largest provider. So we are reforming healthcare. And I do ask, but how come UCLA builds all its clinics within a stone's throw of the beach? Why don't you build over in East LA? Okay, I have disclosure. My day job is here, but my fun job is I'm on the governing board at White Memorial Medical Center in Boyle Heights, right in the middle. My aunt worked there in the 50s and 60s. It's kind of fun. And I'm the board chair for graduate medical education. But it's like night and day to go between here, Ronald Reagan, which is only 12% Medi-Cal and doesn't want any more. And White Memorial is about 90% Medi-Cal Medicare, and the doors are open. So yes, we have a lot of healthcare reform to do, but stuck in most senior policymakers' minds in the UC system, minority means, oh my God, right? Pathological behavior, they're smoking, drinking, doing drugs, beating each other up, stabbing every Saturday night, don't know how to live, don't know how to cook decent food. That is what they carry in their minds. And this is what they research. Why do we know so much about diabetes in Latinos when we don't know about diabetes and heart disease? You would think that should be the #1 item on every medical school dean's list of the things we got to do today. How do Latinos manage to reduce the risk for heart disease by 30%? I know many of the deans, probably about 30 personally. And when I tell them this, they say, that's not true. Can't be true. That's not what I saw in the news. That's not, we have this wonderful project to pull them out of this abyss of bad behavior. What do you mean bad behavior? This is how we get code bias in healthcare research. So you will continue to see this African American, American Indian, Alaska Native, Asian and Pacific Islander, and Hispanic citizens suffer poorer health and higher rates of premature death than the majority population. So what I'd like you to do for about 5 minutes, if you could just turn to people next to you and just discuss amongst yourself, and like you 3, maybe you 4, you 2, 3. What was the most interesting thing you just learned about the Latino epidemiological paradox? Yeah, well, the head smacking moment.
Interesting. There has become a fly. I didn't realize it was that. started thinking that way. Yeah. Oh. Yes. That's what, probably don't. I think I'll have that. Yeah.
About a minute, let's share, just bring your thoughts to a close. Ooh, this is gonna be a problem because I'm asking every group to chat. Just right before COVID, I was invited back to a conference at NIH on race, ethnicity, and genomics and the old precision medicine initiative. Remember that? It was a small group, about the size of this room. It was just internal, it's not a public. And I had 3 institute directors in the room. I showed them these data. Their jaws dropped. And one of the directors of an institute of the National Institutes of Health said, this is 2019, I have never seen these data before. Where did you get them? They're your data. You notice I sourced their CDC data. They're his data. He had never seen. Okay. Sorry, I got.
I'm gonna change the audio settings. I think we can fix this.
Make sure you're- might have- Wait, basically, COVID punished Latinos for showing up for work.
Yeah.
But that's not what you heard. And look at here you is from. And I'm thinking, I'm just a simple engineer. Yeah, I'm not doing fancy modeling. Can we just look at the data? That's what I was trained to do as an engineer. We start with the data. Then we design the structure. We don't design the structure and plop it down anywhere. Okay. How about this? Go ahead. Oh, come on. You mean that thing was interesting?
Oh, yeah. I love everything.
Can you speak up? People need to hear you.
So we were just talking how, what, I wasn't expecting the difference. We just assumed that Latinos had a different outcome. We're just wondering that they live longer, but with.
Let me tell you, after 78, you ask me every morning. Any day I wake up is a good day. Well, you have to wonder about that, but there's quality of life to get there too. Now, is it the quality of life that people in Beverly Hills would want to follow? I don't know. But it's not genetics and it's not some secret Aztec herb, because we see it with Caribbeans too, with Puerto Ricans, Cubans, Dominicans. So the easy answers for me are off the table. But it has something to do with lifestyle and the racial narratives that we as researchers bring in. I mean, to even think the phrase healthy Latino lifestyle, that gets you laughed out of most classrooms here at CHS. And I know what goes on in these classrooms. I know. Impossible. Oh, how do you explain this? I'm sure we make a few adjustments, it'll all go away, and we have looked at this one site. There can be some issues in reporting, but that goes with all large data set, but not to offset 30% lower for harm. And that's multiple standard deviations away. When you do a randomized clinical trials, they get 10%. Oh man, this is keys at 5%, I think is a big deal. But you said something that you were unaware, and so you assumed.
Right, so I work in a,
Talk about, unpack that a little bit more.
so I work in a county facility, and all the patients that come in have diabetes, hypertension, and high cholesterol, and there's so they're all very sick, and they don't have access to care, especially with COVID, they can't make appointments, their next appointment is like in 4 months. So they come into the emergency department and we no.
Yeah.
So they don't all stay, they go home and they. So it's just a cycle and they don't have access to healthcare as maybe I do. I went to urgent care last night and I was in and out.
I was sharing some of these data about 20 years ago in San Antonio. 30% lower age-adjusted death rate from heart disease. man in the back, I'm sorry, that's not true. Latinos have the highest rate of heart disease, this and that, and the other. Okay, I'll put it in cardiology. That's what he sees. But you have to, how does that relate back to the general population? About 5% of Los Angeles County will spend a night in a hospital this year, about 5%. The other 95%. And in healthcare, we tend to get the people who are sick. Guess what? I mean, if you go to see a provider this time of day, well, first of all, how can you bill that, right? You can't have friends when you're in medicine. So we tend to see the outliers and then assume back. Everybody must be, I see that all day in my office. But that's why it's important to look at the big picture, the demographics, the epidemiological. Okay. How about in the back? Just the most interesting thing that just kind of smacked you up the side of the head.
But the Latino health is actually better than the whites.
That was a surprising thing.
Maybe not going to the healthcare is better for you.
Like this, because we norm everything in this country on what non-Hispanic white populations do. That's why we call it the paradox for Latinos. So it's not supposed to be like this, but it is. The party has to wonder, you know, folks in Beverly Hills, how with so much education, so much access, so many Mercedes-Benz, their health is a rock compared to Latino in East LA. Yet most folks in Beverly Hills wouldn't drive through Boyle Heights with their windows rolled up, and the doors locked because they're afraid they're going to get carjacked. But something out there would reduce the risk for heart disease by 30%.
The whites' good life, that's killing them, right?
No,
Better food, the better house, the
good?
better car. So the Latino has to walk more, eat more simpler foods. Yeah, lifestyle, it's a key.
who knows? Your mind. With foods like that, you gotta have, those are great foods.
Thank you. I wasn't here the whole time, but I will say that what I've heard has, to a point, this didn't surprise me.
Okay, someone who's not surprised. Unpack that a little bit, please share with us.
Well, in the patient population, actually, when I'm in the clinic, you're right, you only see those who are sick. Most of the time in education, we're not taught how to see the forest first, then the trees. And so from my background, I look at the forest first, then I see the trees. So basically what I'm trying to do in clinical practice to get the person who has an illness, if possible, back to normal, because I see that this is not being. Yes, there are a population or a group of individuals who may present with something more often, but when you're in a sick environment, all you're going to see are those who are sick. And usually with research, we're looking at those who are sick, not those that are healthy. There is also the opportunity that we've heard about blue zones. There are a lot of blue zones, different places. There is a possibility that we have more blue zones, but if we change the frame of reference in which we look for them, then you will identify them. The other thing is we also have the data that shares that when you come to the United States, your first generation does well. It's your second, third, and fourth generation that start to having more illnesses prevalent to the country in which you live. So in that case, similar to what I said before, is if you take on the environmental standard of health, then there's a possibility that more likely sooner you're going to demonstrate those outcomes. But as you demonstrate in some of the data, you're looking at individuals who are just coming to the United States. Their environment, their societal structure kind of provides that buffer in which they stay healthier until they have come into a system in which they normalize to the standard of the community in which they now work.
And that sparks off just a couple of trains of thought. One of which has to do with the effect of size. Not the effect size, but the effect of size. When I was a kid growing up, there were very few Latinos in this state, and I was born here. My family's been in LA for about 130 years. When I started at UC Davis, and I was the only Latino. And there were 2 African Americans, about a half a dozen Asians, and that was it. And then one weekend, my roommate's brother, who's at Berkeley, came visit, and he said, "Oh, did you know there are 25 Chicanos at Berkeley?" 25. I went down, and checked out, I transferred. I thought I tried went to heaven. 25 Chicanos at UC Berkeley. And we were jealous. UCLA had 70%, 70. Now you go to LAUSD schools, 80% of the enrollees are Latino. So I have to wonder, at that point, who's assimilating to whom? I don't know, but it's different when you're like the one person in the classroom. And when suddenly you're 3/4 of the people in the classroom, just, okay, just what's that interaction? I don't know, by the way. Same population has changed. Boy, has it changed. I was taught, again, as an undergraduate at Berkeley in the 60s, that Latinos were going to disappear. After 1990, no one would speak Spanish. We were just nostalgic, third generation, whatever. But it wasn't really that important to us. And there wouldn't be any more Latinos after 1990, 2000. Okay, that was not right. It was based on the experience of European immigrant groups, but Latinos are different. Really, really different. So that's what I'm trying to figure out, how and why. Don't know that.
We have a question in the chat.
I have a question, okay. Can you read it out? Where do I need to stand to? Question.
Dr. Hodge, if you can unmute, you can just ask it over the audio.
All right, thank you. I wanted to add on to the last discussion and bring to your attention that we can't lose sight of the threats to the paradox. And I'm thinking about environmental justice. As you're well aware, there's a lot of unequal injustices with contamination with the environment, with uranium mining, nuclear waste, gold and other mining runoffs on reservations, and also the 1969 Agent Orange contamination of the Apache reservation, which they never told the tribe about and actually sprayed a schoolyard and all the kids in 1969, and that is carcinogenic. With farm workers, with DDT, all of this threatens the paradox you're talking about, and I think that it demands equal attention. Thank you.
All right. Well, absolutely. If you all saw the Oppenheimer movie and he explodes, but they didn't talk about were the downwinders, all the Latinos and Native Americans live downwind, never told anything, never given any explanation. And that is going to clearly start to erode some of the effects of the paradox. No question about it. Why didn't we tell them? At least the scientists got goggles. Remember the movie? They were behind protection, not the civilians. And it's not the first time this has happened. But the idea that somehow, well, they're already so unhealthy, we can do whatever, they're not going to notice. Clearly, it's not a good place to start. Thank you so much. Okay, we're at 5 up. So I understand I just got the high sign. You're scared to pop right out the hook. Get off stage.
Just a group of us have to leave, so we have class.
Like at least.
I understand. We all have things to do. So.
No, we're coming. Grab some snacks on your way out if you'd like.